Welcome to the Deep Dive, where we strip away the noise and get to the heart of what really matters, equipping you with insights that make you genuinely well-informed. Today, we're plunging into a world that, while microscopic, has colossal implications for your health and safety. We're talking about the agents we deploy in the unseen battle against microbial invaders. Every day, these forces are at play, keeping you healthy, your food safe, and our hospitals from becoming, well, breeding grounds for infection. Understanding these tools isn't just for medical professionals, it's a fundamental part of mastering how we stay safe in a microbial world.
That's precisely what we're aiming for in this deep dive. We're going to navigate this complex landscape on two crucial fronts. First, we'll zero in on specific antimicrobial drugs, those targeted internal warriors designed to fight infections inside the body. Then we'll shift our focus to the broader arsenal of disinfectants, antiseptics, and sterilants that are the guardians of our external environments, from the surfaces in your home to critical medical equipment. Our mission here is to distill the nuances, the precise mechanisms, and the critical distinctions that empower you to understand these topics like a seasoned pro. You'll grasp not just what these agents are, but how they work, and maybe most importantly, why that knowledge is so vital. We've pulled our insights from authoritative pharmacology textbooks so you know you're getting robust, reliable information.
Right. So consider this your fast track to becoming an expert in microbial combat. We're here to extract those profound nuggets of knowledge, those surprising facts, and those satisfying aha moments that transform complex science into captivating conversation. Let's unlock this crucial knowledge.
Spotlight on specific antimicrobial agents targeted internal warfare.
Okay, let's launch into the internal front of this unseen war. We're exploring compounds designed to specifically target bacterial and parasitic invaders within the human body. Our first specialist is one you might have heard of, metronidazole.
Metronidazole. It's truly a fascinating compound, and understanding its unique mechanism is really key to appreciating its power. It belongs to a class of drugs called nitromidazoles. Now, while it's renowned as an antiprotozoal drug...
Meaning it targets things like parasites?
Exactly, single-celled organisms like those responsible for trichomonas or Giardia infections. But, and this is important, it also possesses potent antibacterial activity. Particularly against bacteria that thrive in environments without oxygen, we call those anaerobes. Think common culprits like bacteroids or clostridioides, often found lurking in complex infections deep within the body.
Okay, so how does it manage to be so selective? How does it effectively target these specific invaders while, largely leaving our own cells or even other types of bacteria unharmed? That seems incredibly sophisticated.
This is where the magic, or rather, the molecular genius of metronidazole lies. It's like a molecular guided missile with a very specific activation switch. The drug itself isn't directly toxic. It's what we call a prodrug. It only becomes active once it undergoes a crucial transformation.
Yep.
And this activation specifically happens inside anaerobic bacteria and sensitive protozoa. These organisms possess unique metabolic pathways, like the presence of an electron carrier molecule called reduced ferredoxin. In their low oxygen environment, this molecule can chemically reduce metronidazole.
Ah, okay.
And it's not really an enzymatic process in the usual sense. It's non-enzymatic reduction. This transforms metronidazole into highly reactive toxic byproducts. These toxic compounds then accumulate within the anaerobic cells and are taken up into the invader's DNA.
Wow.
They form unstable molecules that fundamentally scramble its genetic blueprint, effectively shutting down the cell.
So it messes with the DNA directly?
Pretty much. And our human cells and most aerobic bacteria, they simply lack this specific activation switch. They don't have the unique metabolic conditions or specific electron carriers necessary to reduce metronidazole in this way. That's why it's so selective and why it has minimal effect on our own cells or on aerobic bacteria. It's truly targeted internal warfare at a molecular level.
That's a profound aha moment right there. A drug that literally arms itself only when it's inside the enemy. Once this molecular guided missile is deployed, how does it actually travel through the body to reach all those deep infection sites? Does it get everywhere?
Its journey through the body is quite efficient, which is a major advantage. Metronidazole is exceptionally well absorbed after you take it orally, meaning it quickly and effectively enters your bloodstream. From there, it distributes widely throughout the body's tissues. For instance, a typical 250 milligram oral dose can achieve serum levels of about 46 micrograms per milliliter.
Okay.
But what's truly critical for its clinical utility is its remarkable ability to penetrate into difficult-to-reach areas. We're talking cerebrospinal fluid, the brain itself.
Really? Into the brain?
Yes. reaching concentrations almost identical to those in the blood. This makes it indispensable for treating serious infections like brain abscesses. The body primarily processes and metabolizes metronidazole in the liver. So this means for individuals with significant liver problems, we need to be really careful with dosing. The drug can accumulate to potentially toxic levels if not adjusted.
Right, that makes sense. So it's got this incredible reach within the body. Given that, where do we see metronidazole making the biggest clinical impact? What are its main uses?
Its clinical indications are quite broad, but they almost always circle back to those anaerobic or mixed infections. It's a cornerstone in treating intra-abdominal infections, especially when you suspect both aerobic and anaerobic bacteria are involved, which is pretty common. It's also a key component in treating pelvic inflammatory disease, usually as part of a multi-drug regimen that also targets aerobic bugs. For more common conditions like vaginitis, it's highly effective against Trichomonas vaginalis and bacterial vaginosis. And as we touched on, its ability to get into the central nervous system makes it vital for brain abscesses. Now, for Clostridioides difficile infection C, that major challenge causing severe diarrhea. Metronidazole used alone is no longer considered a first-line therapy.
Ah, okay. That's changed then.
Yes, that's an important update. However, it still holds a critical niche. In severe, what we call fulminant cases of C. diff infection, it's often given intravenously combined with oral vancomycin, providing an extra layer of attack.
Got it. And when a doctor prescribes it, are we talking about a long course of treatment, or can it sometimes be a quick fix?
The dosage really varies based on the infection and how severe it is. For many uses, a typical adult dosage is 500 milligrams 3 times daily, either orally or IV. Or you might see it dosed by weight, about 30 milligrams per kilogram per day. For simpler localized infections like certain forms of vaginitis, a single 2-gram oral dose can be remarkably effective. And it's also available as a vaginal gel for topical treatment in specific cases.
What about side effects? And I definitely remember hearing something about a strict warning against drinking alcohol with metronidazole. Is that still the advice?
Good question. Common adverse effects tend to be gastrointestinal, think nausea, diarrhea, and mouth sores, which we call stomatitis. With prolonged courses, peripheral neuropathy, that's numbness or tingling in the hands or feet, can occur, which is why long-term use is typically monitored carefully. And you're absolutely right to ask about alcohol. For many, many years, it was a deeply ingrained belief that metronidazole caused a severe disulfiram-like reaction with alcohol.
Like the drug they give to deter drinking.
Exactly. Leading to symptoms like flushing, headache, severe vomiting. This led to strict warnings for patients to avoid alcohol completely. But here's what's truly fascinating. A reevaluation of the scientific literature has largely debunked this long-held belief.
Really? So you can drink with it?
Well, I wouldn't put it quite like that. While some individual reactions might still happen, it's now understood not to be a widespread universal phenomenon like we thought. It's a significant update for clinical practice. Another point, while animal studies showed some potential for birth defects, metronidazole has thankfully not been associated with these effects in humans.
That reevaluation is a really important takeaway. It shows how science evolves. Are there any other drugs similar to metronidazole we should know about?
Absolutely. Tinidazole is structurally quite similar. An advantage is it can often be dosed just once daily. It's approved for several of the same protozoal infections, Trichomonas, Giardia, amoebiasis, and also bacterial vaginosis. It also shows activity against anaerobic bacteria, much like metronidazole. However, a key difference, at least in the U.S., is that it's not broadly approved for treating general anaerobic infections, which kind of limits its scope compared to metronidazole.
Okay, interesting. All right, from that broad spectrum specialist to maybe a more precise gut defender, Fidaxomicin. This sounds like it really zeroes in on a particular type of infection.
Fidaxomicin is indeed highly targeted. It's categorized as a narrow-spectrum macrocyclic antibiotic. This means its activity is quite specific. It's highly effective against gram-positive aerobes and anaerobes. But critically, it has virtually no activity against gram-negative bacteria. This selectivity is very much by design.
So how does it manage to be so specific? What's its unique mechanism?
Its mechanism of action is very precise. Fidaxomicin works by inhibiting bacterial protein synthesis. It does this by binding specifically to the sigma subunit of RNA polymerase. That's an enzyme absolutely essential for bacteria to make the proteins they need to live and replicate. By basically gumming up this machinery, it stops the bacteria's ability to function and multiply.
And how does that mechanism combined with how it moves through the body shape where it's used clinically?
This is a prime example of pharmacokinetics dictating clinical use. When fidaxomicin is taken orally, its systemic absorption is almost negligible, less than 0.005%.
Wow, tiny.
Extremely tiny. And that's crucial, because so little gets into the bloodstream, it stays largely confined to the gastrointestinal tract. This means two things. First, very few systemic toxicities, a big safety plus. Second, you get extremely high concentrations of the drug right in the feces, exactly where it's needed for gut infections. This unique profile means its use is intentionally restricted to treating infections that are, by nature, confined to the digestive system.
So if it stays in the gut, what specific infection is it the go-to for?
Given its gut-focused action and strong activity against those gram-positive anaerobes, fidaxomicin is approved for treating Clostridioides difficile infection in adults. C. diff again. And here's the really significant takeaway for professionals. While its effectiveness in killing C. diff is comparable to oral vancomycin, it has a distinct advantage. Clinical studies and guidelines now recommend fidaxomicin as the preferred first-line agent for C. diff.
Preferred? Why is that?
Because it significantly lowers the rates of relapsing disease compared to oral vancomycin. C. diff is notorious for coming back after treatment, so anything that reduces that relapse risk is a major breakthrough.
That's a powerful distinction, reducing relapses. What's the typical dosage for this targeted gut defender?
Fidaxomicin is typically given as a 200 milligram tablet, taken twice daily, and the usual course of treatment is 10 days.
All right, from one gut specialist to another, let's turn our attention to rifaximin. It sounds like it shares some characteristics with fidaxomicin, that gut-specific action, but maybe with broader uses.
You're astute to notice the similarity. Rifaximin is actually a derivative of rifampin, another well-known antibiotic. Like rifampin, it has a broad spectrum of activity effective against both gram-positive and gram-negative bacteria, both aerobes and anaerobes. Its mechanism is also about inhibiting bacterial protein synthesis. It binds to the beta subunit of DNA-dependent RNA polymerase, basically jamming the machinery that turns genetic code into proteins.
And like fidaxomicin, the key here is its gut specificity, right?
Yeah.
How limited is its absorption, and what does that mean for its concentration down there?
That's its defining characteristic, absolutely. Rifaximin exhibits truly minimal systemic absorption, typically less than 0.5% when taken orally. This is critical, because so little gets into the bloodstream, it leads to incredibly high concentrations directly within the lumen of the GI tract. To give you a sense of scale, after just a 3-day course for traveler's diarrhea, fecal concentrations have hit an astonishing 8,000 micrograms per gram.
8,000, that's huge.
It really is. This allows it to exert powerful therapeutic effects locally in the gut without causing widespread systemic side effects. And it dramatically reduces the risk of developing systemic resistance that could affect other critical antibiotics.
That's impressive concentration right where it's needed. Given its gut focus, what are its major clinical applications? It sounds like it could be quite versatile.
Rifaximin is surprisingly versatile. It was originally approved for traveler's diarrhea, as you mentioned, but its utility has expanded significantly. It's now a primary treatment option for hepatic encephalopathy, that serious neurological complication of advanced liver disease.
How does it help there?
By reducing the number of ammonia-producing bacteria in the gut, rifaximin helps decrease the amount of toxins reaching the brain. It's also approved for irritable bowel syndrome with diarrhea, IBS-D, where it helps modulate the gut microbiome. And circling back to C. diff, rifaximin is occasionally used as an adjunct therapy in cases of recurrent or refractory C. diff in adults, building on its ability to modify the gut flora.
Given its limited absorption, does that affect how it interacts with other medications, especially liver enzyme stuff?
That's an excellent professional-level question. Typical doses range from 200 to 550 milligrams orally, 2 to 3 times daily, depending on the use. And precisely because its systemic absorption is so limited, rifaximin is generally not associated with those cytochrome P450-mediated drug interactions. This is a significant clinical advantage because other rifamycins are potent inducers of these enzymes, causing lots of interactions. Rifaximin's minimal systemic impact simplifies things, especially for patients on multiple drugs.
Okay, good to know. Let's shift from the gut to the skin. And Mupirocin, a topical agent. What's its origin and how is it typically used?
Mupirocin is an interesting natural product, originally found in the bacterium Pseudomonas fluorescens. It's predominantly used as a topical ointment because it gets rapidly inactivated after absorption through the skin, resulting in undetectable systemic levels. This means it delivers its punch exactly where you put it, without affecting the rest of the body, ideal for superficial skin infections.
What kind of bacteria does it target on the skin, and what's its specific mode of action? How does it kill them?
Mupirocin is highly active against gram-positive Kachi. This includes the formidable Staphylococcus aureus, both the regular methicillin-susceptible strains, and, crucially, methicillin-resistant Staphylococcus aureus, MRSA. Its mechanism is remarkably specific. It uniquely inhibits an enzyme called staphylococcal isoleucyl tRNA synthetase.
Okay, what does that enzyme do?
It's absolutely vital for Staphylococcus bacteria to synthesize proteins, the building blocks of life. By jamming this specific enzyme, mupirocin effectively halts protein production and thus bacterial growth. This narrow, precise target is key to its effectiveness against these bugs.
That's a very specific attack. But with such a targeted drug, what about resistance? Is that a major concern?
Resistance is always a critical consideration, and mupirocin is no exception. We see two main types. First, there's low-level resistance, usually indicated by an MIC that's minimum inhibitory concentration up to 100 micrograms per milliliter. This usually comes from a subtle point mutation in the gene for the target enzyme. While this can emerge with prolonged use, the good news is the very high local concentrations you get with topical application are usually way above this MIC, so it often still works.
Okay, so low level might be manageable. What's the other type?
The more concerning form is high-level resistance, with MICs over 1,000 micrograms per milliliter. This is a game changer because it's caused by the bacteria acquiring a second plasmid-encoded isoleucyl tRNA synthetase gene. This basically makes mupirocin completely ineffective.
Wow.
Yeah, and this high-level resistance has been definitively linked to hospital-associated outbreaks of staph infection and colonization. While extensive use has led to increased resistance rates, it's important for professionals to remember that most Staphylococcus isolates are still susceptible, especially for short-term targeted uses.
So where is mupirocin best utilized, and are there any situations where its use is actively discouraged?
It's primarily indicated for the topical treatment of minor skin infections, like impetigo. Now, for anyone aiming to master this, here's a crucial professional insight. It is strongly advised against topical application over large open areas, like pressure ulcers or extensive surgical wounds.
Why is that?
Because this provides a large surface area and prolonged exposure, significantly contributing to the selection and emergence of those resistant strains, particularly high-level resistant MRSA, which can then spread. That's a big problem. While its effectiveness in preventing recurrent staph infections is debated, mupirocin is invaluable for temporarily eliminating S. aureus nasal carriage in patients or healthcare workers. This nasal decolonization is particularly beneficial before high-risk surgeries like orthopedic or cardiothoracic procedures, where preventing staph infections can literally be life-saving.
Got it. Finally, in this section, let's talk about polymyxins. I've heard these antibiotics were largely shelved due to toxicity, but are now making a critical comeback against superbugs. What's the story here?
You've hit on one of the most compelling comebacks in modern antibiotic history. The polymyxins are a class of basic peptides, with polymyxin B and polymyxin E, often called colistin, being the main ones. Historically, their use was indeed severely limited due to significant systemic toxicities, most notably severe nephrotoxicity or kidney damage. For a long time, they were just seen as too dangerous for widespread internal use.
So what's their specific target, and how do they actually kill bacteria?
Their spectrum of activity is almost exclusively against gram-negative bacteria, making them a very narrow but potent weapon. Gram-positive organisms, plus things like Proteus and Neisseria, are naturally resistant. The mechanism is quite dramatic. Polymyxins act as cationic detergents. Think of them as tiny charged wrecking balls. They strongly bind to the negatively charged outer membrane of gram-negative bacteria. This attachment literally disrupts the integrity of the bacterial cell membrane, causing vital stuff inside to leak out, leading to rapid bacterial death. A fascinating extra property is their ability to bind and inactivate endotoxin, a powerful inflammatory component released by gram-negative bacteria that contributes to sepsis.
So before their resurgence, how were they typically used, given that toxicity?
Precisely because of the systemic toxicity, especially the kidney impact, their use was largely confined to topical applications. You'd commonly find polymyxin B in ointments, often combined with other topicals like bacitracin or neomycin, applied to superficial skin lesions or minor wounds. This let us harness their potent action locally without risking systemic side effects.
But now, with the frightening rise of multi-drug-resistant superbugs, they're being reevaluated for serious systemic infections. This sounds almost like a desperate measure.
It is indeed a testament to the urgency of the antibiotic resistance crisis. The critical shift began with the global emergence of multi-drug-resistant strains of really formidable gram-negative pathogens, like Acinetobacter baumannii, Pseudomonas aeruginosa, and various Enterobacteriaceae, including carbapenem-resistant strains, the so-called CREs. These organisms have developed resistance to nearly all other available safer antibiotics. In this incredibly challenging landscape, there's been a renewed and urgent interest in using polymyxins parenterally, meaning 4Z, as a last line of defense. This is often called salvage therapy, highlighting their importance as a crucial, albeit toxic, tool for treating life-threatening infections where literally no other options remain. Understanding their unique role here is crucial.
Urinary antiseptics targeting the tract.
All right, we've covered some powerful internal warriors. Now let's narrow our focus to a very specific area, the urinary tract. What defines these agents, often called urinary antiseptics, and why are they distinct from the systemic antibiotics we just discussed?
Urinary antiseptics represent a unique class of oral antimicrobial agents. Their defining characteristic, and a critical professional distinction, is that their antibacterial activity is exerted almost exclusively within the urine. This means they have very little to no systemic antibacterial effect. They don't circulate widely through the body to fight infections elsewhere. Because of this localized action, their primary use is limited to lower urinary tract infections in the bladder or urethra. They are generally not effective for infections higher up, like kidney infections or for systemic infections.
That's a crucial distinction. Let's delve into nitrofurantoin, a very common and increasingly important urinary antiseptic. What's its spectrum of activity and why is it gaining importance?
Nitrofurantoin, at the doses we use, is bactericidal for a wide range of gram-positive and gram-negative bacteria commonly found in UTIs. However, it's important to note its limits. Pseudomonas aeruginosa and many strains of Proteus are inherently resistant. What makes nitrofurantoin increasingly valuable, especially for professionals, is its lack of cross-resistance with other major antimicrobial classes.
Meaning resistance to other drugs doesn't usually affect it.
Exactly. Bacteria resistant to common UTI treatments like trimethoprim, sulfamethoxazole, or fluoroquinolones, which unfortunately is becoming more prevalent, particularly in E. coli, the main cause of UTIs are often still susceptible to nitrofurantoin. This makes it a vital alternative oral agent for uncomplicated UTIs, especially as resistance patterns change.
The mechanism of action for some of these drugs can be incredibly complex. How exactly does nitrofurantoin manage to kill bacteria in the urine, even if we don't know everything?
You're right, its mechanism is surprisingly intricate and still not entirely worked out, which adds to its scientific interest. What we do understand is that its activity had linked to rapid intracellular conversion. Basically, once nitrofurantoin gets inside a bacterial cell, specific bacterial enzymes called reductases quickly transform it into highly reactive intermediate compounds. These intermediates aren't picky. They react non-specifically with various vital components inside the bacterial cell, particularly key ribosomal proteins. This widespread disruption messes up the bacteria's metabolism and the synthesis of essential proteins, RNA, and DNA, ultimately leading to cell death. It's like setting off a chaotic internal explosion within the bacterial cell triggered by its own enzymes.
That's quite the internal sabotage. How does this rapid action in the urine, combined with minimal systemic effect, lead to issues for patients with kidney problems?
It's a delicate balance. Nitrofurantoin is well absorbed orally, but then it's metabolized and excreted so rapidly that its concentration in the bloodstream is negligible, no systemic action. Its therapeutic effect relies entirely on its rapid excretion into the urine, which happens through both glomerular filtration and tubular secretion in the kidneys. This ensures high urine concentrations, maybe 200 micrograms per milliliter. However, here's the critical point for clinical practice. In patients with significant renal impairment, the kidneys just can't excrete the drug efficiently enough into the urine to reach therapeutic levels. At the same time, the drug can accumulate to higher, potentially toxic levels in the bloodstream.
So it doesn't get where it needs to go and builds up elsewhere.
Precisely. Because of this, nitrofurantoin is generally contraindicated in patients with significant renal insufficiency. The traditional benchmark has been to avoid it if creatinine clearance is less than 60 millimoles per minute. Although some more recent data suggests short-term use might be okay for those with clearance above 30 alamin, but this really requires careful clinical judgment.
So potent urinary cleaner, but Kidney function is a major watch-out. What are the common dosages and formulations? I think there's a sustained release version.
Yes, for uncomplicated UTIs in adults, the typical dosage is 100 milligrams orally, 4 times daily. A very common and convenient alternative is the long-acting formulation known as Macrobidid, which is taken just twice daily. The Macrobid capsule is ingeniously designed. It contains 2 distinct forms of nitrofurantoin. About 25% is microcrystalline, which dissolves and absorbs slowly. The other 75% is nitrofurantoin monohydrate, blended into a powder. When this hits the acidic stomach and intestines, the powder forms a gel matrix. This gel then slowly and continuously releases the drug over time, providing a sustained therapeutic concentration in the urine with less frequent dosing. It's a great example of pharmaceutical engineering.
What are its limitations beyond kidney issues, and are there ways to boost its activity in the urine?
Beyond renal insufficiency, a crucial limitation is that because of its localized action, nitrofurantoin should not be used for upper urinary tract infections or pyelonephritis kidney infections, as drug levels in the kidney tissues themselves would be too low. A key factor influencing its efficacy is urinary pH. Its activity is significantly enhanced if the urine pH is kept below 5.5.
So acidic urine helps.
Yes, considerably. While things like diet or acidifying agents like ascorbic acid might help, though you need large doses, 12 grams a day, not always practical, it's an important aspect for optimal performance. It's also widely used for preventing recurrent UTIs in some women, often with a single daily 100 milligram dose as prophylaxis.
And finally, what are the most common side effects and any significant drug interactions professionals need to watch for?
The most common side effects are gastrointestinal anorexia, nausea, vomiting, which can sometimes limit tolerance. More serious, though less frequent, are neuropathies and pulmonary toxicities, especially with prolonged use or in patients with impaired kidney function. Hemolytic anemia, the destruction of red blood cells, can happen in people with an underlying G6PD deficiency. In terms of drug interactions, nitrofurantoin can antagonize the action of nalidixic acid and some older fluoroquinolones like norfloxacin and ciprofloxacin, so using them together should be avoided or very carefully considered. Other reported issues include skin rashes, pulmonary infiltration fibrosis with long-term use, and other hypersensitivity reactions.
That's a comprehensive deep dive into nitrofurantoin. Next up, we have methenamine mandellate and methenamine hippurate. What makes these urinary antiseptics different in how they work, especially regarding pH?
These agents are truly unique in their pH-dependent mechanism, offering another fascinating insight. Methenamine mandellate is a salt of mandelic acid and methenamine, and similarly, methenamine hippurate is a salt of hippuric acid and methenamine. The critical element here is the methenamine part. Once absorbed and excreted into the urine, methenamine releases formaldehyde, which is a potent, non-specific antibacterial agent. But here's the catch, the core of their mechanism. This release of formaldehyde only happens when the urine pH drops below 5.5.
So it needs acidic urine to work at all.
Exactly. The mandelic and hippuric acids themselves are also absorbed and excreted unchanged in the urine, and they serve a crucial dual purpose. They help maintain that necessary acidic environment, ensuring the methenamine breaks down to its active form.
So their entire effectiveness hinges on highly acidic urine. Does that limit their activity, and what are they primarily used for?
Precisely. Their bactericidal activity is strictly limited to some gram-negative bacteria, and only when the urine pH is less than 5.5. This pH dependency is their defining characteristic, and this is a very important professional distinction. These drugs are used solely as urinary antiseptics for prophylaxis, that is, to prevent recurrent UTIs. They are not effective for treating active, symptomatic UTIs. The formaldehyde release is relatively slow and non-specific, making them unsuitable for acute infections where you need rapid bacterial killing. Their role is just to suppress bacterial growth in the bladder.
How are they typically dosed, and are there any critical warnings or drug interactions, especially related to keeping that urine pH low?
For adults, methenamine mandellate is typically 1 gram orally, 4 times daily. Methenamine hippurate is often 1 gram twice daily. For kids 6 to 12 years old, it's 500 milligrams, 4 times daily for mandellate or twice daily for hippurate. To help ensure the urine pH stays below that critical 5.5 threshold, acidifying agents like ascorbic acid, vitamin C, sometimes in significant doses, 12 grams per day, might be given alongside it. Now, here's a crucial warning for clinical safety. Sulfonamides, the sulfa drugs, should never be given concurrently with methenamine.
What?
Because they can react with the formaldehyde released by methenamine to form an insoluble compound, potentially leading to crystals in the urine and kidney damage. Very important interaction to avoid. Another interesting point, patients taking methenamine mandolate might show falsely elevated tests for urinary catecholamine metabolites, which could confuse certain diagnostic tests.
Disinfectants, antiseptics, and sterilants, the environmental guardians.
Okay, we've explored the targeted internal warriors. Now we pivot to the equally vital battle for our external environments. And here's where it gets really interesting. The terminology can be incredibly nuanced and, frankly, a bit confusing sometimes. But for anyone serious about mastering this, understanding these precise definitions is absolutely fundamental. Can you break down the core terms for us?
You've hit on a critical point. Precision in language is paramount here. Let's lay out the primary categories and related processes as defined in our sources so you can really get the distinctions. First, disinfectants. These are chemical agents or physical procedures specifically designed to inhibit or kill microorganisms on inanimate surfaces. Think hospital countertops, instruments, your kitchen counter.
Okay, non-living things.
Right. Then antiseptics. This is a very specific subset. Antiseptics are disinfecting chemical agents with low enough toxicity that they can be safely applied directly to living tissues, skin, mucous membranes, wounds for infection prevention, so for the body's exterior.
Got it. Disinfectant for surfaces, antiseptic for skin.
Exactly. Then sterilants. These are the ultimate microbial destroyers. Sterilants are agents capable of killing both vegetative cells and bacterial spores. They're really tough forms when applied correctly. Their goal is complete elimination.
Spores, too. Okay.
Now let's clarify the processes. Antisepsis is the application of an antiseptic to living tissue. Decontamination is a broader term aiming for a marked reduction in microbes to make something safer to handle. Disinfection is a treatment destroying most vegetative microbes and viruses on inanimate surfaces, but crucially, it generally does not reliably kill bacterial spores.
Ah, so disinfection doesn't guarantee killing spores. That's important.
Very important. Sanitization reduces the microbial load on inanimate surfaces to acceptable public health levels, like in food service. Sterilization is the most rigorous, intended to kill or remove all microorganisms, including spores and usually viruses, with a very low probability of anything surviving. Highest level of control. And pasteurization is a specific heat treatment, usually 65-100 degrees C, killing non-spore-forming bugs, often used for food and drinks.
That's incredibly helpful. So disinfection is about reducing the threat, not necessarily eliminating everything, and it can be physical too, not just chemical. How do these different methods work together?
Precisely. Disinfection aims to prevent infection by reducing the number of potential pathogens. You can kill them, physically remove them, or dilute them. Chemical agents are one way, but physical methods are also key. Ionizing radiation, dry heat, or moist heat like steam in an autoclave at 120 degrees C. Often combinations work best. Pasteurization uses heat and water. Sometimes sterilants like ethylene oxide are used with moist heat, or a disinfectant might be mixed with a detergent to clean and kill. And never underestimate simple washing. Soap and water physically removes and dilutes microbes. Sometimes the simplest methods are profoundly effective.
Given all these methods, what's consistently identified as the single most important thing for preventing transmission? Something for everyone.
For anyone in infection control, the answer is clear. Hand hygiene is probably the single most important and effective means of preventing the transmission of infectious agents. Period. This applies everywhere community spread, preventing transfer from high-load areas like the nose or gut to vulnerable sites. Our main tools are alcohol-based hand rubs, great for killing most transient bugs, and the classic soap and warm water, which physically removes bacteria. In surgery, of course, specialized skin disinfectants with detergents are used in rigorous surgical scrubs before gloving.
It seems like figuring out how well these agents actually work would be incredibly complex. With so many variables, how do experts even assess them reliably?
You're absolutely right. It is incredibly complex. Many factors influence efficacy, like the intrinsic resistance of the microbe itself. Some are just tougher. The number of microbes present, the bioburden. Are you dealing with a mix of bugs? Is there organic material like blood or feces present? That can inactivate many agents. Then there's the agent itself. Its concentration, stability, time and temperature exposure, pH, even how it binds to surfaces. Given all this, you need specific standardized lab assays to really assess effectiveness reliably. And of course, toxicity to humans and the environment is always a huge factor. And for professionals, it's key to know that in the U.S., the EPA regulates disinfectants and sterilants for surfaces, while the FDA regulates antiseptics for living tissues.
That brings us to general cautions. What are the major risks or limitations users, especially pros, need to be acutely aware of?
This is vital. Users must always consider both short-term and long-term toxicity. These agents are biocidal, designed to kill living cells, so they can harm human cells too if misused. There's also potential for accumulation in the environment or body with long exposure. A critical, maybe surprising, caution. The disinfectants and antiseptics themselves can become contaminated.
The cleaner gets dirty.
Exactly. We've seen cases where resistant microbes like spores or tough bacteria like Pseudomonas or Serratia actually grow in the solutions, turning the cleaner into a source of infection. Proper storage and handling are crucial. Also, for topical use, most antiseptics can interfere with wound healing to some extent. Sometimes, just cleaning a wound well with soap and water is less damaging than using a chemical antiseptic.
A closer look at chemical classes, the arsenal.
Okay, let's go even deeper into the specific chemical classes in this arsenal, starting with one we all know, alcohols. How do they dominate antisepsis and disinfection?
The two main players are ethanol and isopropyl alcohol, or isopropanol. Their popularity comes from their rapid and broad activity. They're great against vegetative bacteria, including the tough Mycobacterium tuberculosis, many fungi, and they're excellent at inactivating lipophilic viruses, think influenza or coronaviruses, a key insight. Their optimum bactericidal concentration isn't 100%. It's actually 60–90% by volume in water.
Why is that? Less is more.
Because water is essential for their mechanism, which is mainly denaturing proteins. Unraveling those crucial microbial protein structures needs water present to work best.
So they're excellent killers, but are they complete sterilants, and what are the key practical limitations?
This is a critical distinction. Alcohols are not used as sterilants because they are fundamentally not sporicidal. They cannot kill bacterial spores, period. Plus, they don't penetrate protein-rich organic material well, so blood or tissue can shield microbes. They also might not hit all hydrophilic viruses. Practically, they evaporate quickly, meaning no residual action once dry. They can dry skin, though emollients help. They're flammable, need careful storage, and you must let them evaporate completely before using things like electrocautery to avoid fires. They can also damage corneal tissue, so instruments need rinsing before eye contact.
I know alcohol-based hand rubs are everywhere in healthcare. How do they fit in? And are there times they're not the best choice?
Alcohol rubs have revolutionized hand hygiene. They've unequivocally reduced transmission of healthcare pathogens, including SARS-CoV-2. The CDC recommends them as the preferred method in most clinical settings. They're effective, fast, convenient. However, and this is a critical professional nuance, alcohol rubs are ineffective against the spores of Clostridioides difficile.
Difficile. Alcohol doesn't kill its spores.
Nope. C. diff spores are incredibly tough. For this reason, after caring for a C. diff patient, rigorous hand washing with soap and water is absolutely required to physically remove those spores. The alcohol rub just won't destroy them.
That's a vital detail. Next up, chlorhexidine, another super common one in surgical scrubs, even some mouthwashes. What makes it unique, especially its lasting effect?
Chlorhexidine is a cationic biguanide. Its structure is key. Usually you find the water-soluble form chlorhexidine digluconate in antiseptic formulations. Its spectrum is broad. Vegetative bacteria, mycobacteria, variable against fungi and viruses. Especially good against gram-positive cocci like staph and strep. Less active against some rods. A key professional insight. It inhibits spore germination, but doesn't kill mature spores.
How does it work, and what gives it that persistent protection that alcohols lack? That seems like a major difference.
Its mechanism is different and explains its persistence. Being positively charged, chlorhexidine strongly absorbs, binds tightly to negatively charged bacterial membranes. This binding disrupts the membrane, causes leakage, and at higher concentrations makes cytoplasmic proteins precipitate, basically coagulates the cell's insides. It works well between pH 5.5–7.0. While its initial action might be slower than alcohol, its defining advantage is its residual activity or persistence. Because it binds so strongly to skin, it's slowly released over time, giving sustained killing action.
So it keeps working after it's applied.
Exactly. It can be equivalent to or even better than alcohols over time because of this persistence. It's also pretty resistant to inactivation by blood or organic stuff, though interestingly, things like moisturizers, soaps, surfactants can neutralize it, so proper use is key. 4% formulations are often slightly more active than 2%.
That explains why it's favored for surgical prep. I've seen it combined with alcohol sometimes. What's the benefit there?
Excellent observation. That combination, chlorhexidine gluconate, maybe 2% or 4%, with 70% alcohol is often preferred for skin antisepsis in many procedures, especially in the US. It leverages the best of both. Alcohol gives rapid, immediate kill. Chlorhexidine then provides sustained, persistent activity even after the alcohol evaporates or it's exposed to body fluids. This dual action gives it a significant edge over something like povidone iodine, which lacks that persistent skin activity.
It's really a best practice for surgical site infection prevention.
And its safety profile. Anything unexpected for something so widely used?
Generally, it's very safe. Low skin irritation or sensitization. Low oral toxicity because it's poorly absorbed. However, there are critical warnings for professionals.
Right.
Chlorhexidine must never be used during middle ear surgery. It's linked to deafness. Similarly, caution is needed during neurosurgery due to potential nerve toxicity if it contacts nervous tissue directly. These are absolute contraindications.
Wow. Okay. Moving on to the halogen's powerful oxidizing elements. Let's start with iodine. Iodine is indeed potent. Historically, a 1.2 Cezanne solution was bactericidal in a minute, killed spores in 15 minutes remarkably fast. Tincture of iodine USP, 2% iodine, 2.4% sodium iodide and alcohol, was once the gold standard antiseptic for intact skin. But it's not commonly used today.
Why not, if it's so effective?
Primarily two big drawbacks. First, a relatively high rate of serious hypersensitivity reactions in some people. Second, it notoriously stains skin, clothing, everything deep brown. Just not practical or acceptable in most modern settings.
So that leads us to iodophores like povidone iodine, which are widely used. How are they different? How do they keep iodine's activity but make it less harsh?
Iodophores are clever formulations complexes of iodine with a carrier agent, often PVP, polyvinyl pyrrolidone, hence povidone iodine. They retain iodine's broad-spectrum activity but significantly reduce its irritating and staining properties. They kill vegetative bacteria, mycobacteria, fungi, lipid-containing viruses, may be sporicidal with long exposure but not reliably like sterilants. They can be antiseptics or disinfectants, higher iodine. The key is they contain very little iodine but release it slowly on dilution or contact with skin. This slow release reduces irritation. But, crucial point, they must be diluted exactly as the manufacturer says for full activity. Wrong dilution means less effectiveness.
What are their pros and cons compared to straight iodine or even chlorhexidine?
Compared to tincture, iodophores are way less irritating and less likely to cause hypersensitivity, much more patient-friendly. However, a practical downside is they need drying time on the skin at least 2 minutes to become fully active. Can be slow. While they generally have a broader spectrum than chlorhexidine, including potential sporicidal action, they critically lack chlorhexidine's persistent activity on skin. Once dry, they don't keep working like chlorhexidine does. That's a key difference.
And then there's chlorine, the universal disinfectant, basically household bleach, right?
That's a good way to think about it. Chlorine is a powerful oxidizer, a universal disinfectant, broad spectrum, low cost. Most common is 5.25% sodium hypochlorite solution, household bleach. Though always check the label for exact concentration. It can vary. A critical concentration for healthcare. A 1.1 dilution of household bleach gives 0.525% sodium hypochlorite, providing 5,000 parts per million ppm available chlorine. This 5,000 ppm is the CDC recommended standard for disinfecting blood spills, precisely because it is sporicidal at that level.
What concentrations do we need for different microbes, from easy ones to tough spores?
The required chlorine concentration varies a lot based on the target, shows the precision needed. For general vegetative bacteria, less than 5 ppm might do it, but for bacterial spores, you need up to 5,000 ppm. For Mycobacterium tuberculosis, you need 10,000 ppm to be tuberculocidal. Fungi. 100 ppm kills vegetative cells in an hour, but spores need 500 ppm. Most common viruses are inactivated by 200-500 ppm. It's a graduated scale.
How stable are these bleach solutions once diluted? And any dangerous chemical reactions to worry about? The safety seems huge here.
They're pretty stable if managed right. Dilutions made with tap water around pH 7.5 to 8.0 can last months in tightly closed, opaque containers away from light. But frequent opening or light exposure reduces activity, critical for effectiveness. Chlorine is readily inactivated by organic stuff, blood, serum, feces, proteins. Surfaces must be cleaned first before disinfecting or won't work well. The active agent is hypochlorous acid, HOCl. Higher pH shifts it to the less active hypochlorite ion, OCl. Now, crucial safety. Dangerous reactions can happen. Contact with formaldehyde can form a carcinogen, bischloromethyl ether. Even more important for everyday safety. Mixing bleach with acid, like some toilet cleaners, or even urine causes rapid release of irritating, potentially lethal chlorine gas. Very dangerous. Plus, it's corrosive to aluminum, silver, stainless steel. Material compatibility matters.
Are there alternative chlorine compounds with different benefits?
Yes. Besides sodium hypochlorite, there's chlorine dioxide and chloramine T. These tend to provide a more prolonged bactericidal action, which can be useful sometimes.
Okay. Next on our list, phenolics. I know phenol itself has a long history, but isn't really used anymore due to toxicity. How have its derivatives evolved?
You're right. Phenol, used by Lister way back, is out. Too corrosive, toxic, carcinogenic. Derivatives were developed to reduce these issues while keeping antimicrobial activity. Common ones now include O-phenolphenol, O-benzylchlorphenol, tertiary amylphenol. Sometimes mixtures from coal tar like creosols and xylanols are used. Still, even these derivatives can cause skin absorption and irritation, need protection, often mixed with detergents to help clean off organic material, which can reduce their activity.
How do these phenolic derivatives work? What's their spectrum?
They primarily disrupt cell walls and membranes, causing leakage. They also precipitate proteins and inactivate essential enzymes. Their spectrum is quite broad, oscaricidal, including mycobacteria, fungicidal, and they inactivate lipophilic viruses. However, a crucial limitation: they are not sporicidal, they don't kill spores, so no sterilization. And you must follow manufacturer directions on dilution and exposure time.
Where are they typically used professionally? And any specific critical warnings, especially regarding infants?
Phenolic disinfectants are still used for hard surface decontamination in hospitals and labs floors, beds, countertops. However, here's a critical warning, especially for pediatrics. They are not recommended for use in nurseries, particularly near infants. Their use there has been strongly linked to hyperbilirubinemia, high bilirubin levels dangerous for newborns. A serious historical example. Hexachlorophene, a phenolic derivative, caused brain swelling and seizures in premature infants, leading to its withdrawal in the U.S. Highlights the potential for real systemic toxicity.
All right, let's talk about quats, quaternary ammonium compounds. What are these chemically and how do they work as sanitizers?
Quats are cationic surface active detergents. Their structure is key, an active cation with a long water-repellent hydrocarbon chain. This lets them concentrate on surfaces. The charged nitrogen keeps them dispersed in water. Their killing action is thought to come from inactivating energy-producing enzymes, denaturing proteins, and disrupting cell membranes, causing leakage.
What's their range of activity? What do they hit? What do they miss?
Quats are fungistatic, inhibit fungi, and sporostatic, inhibit spores but don't kill. They inhibit algae. They're bactericidal for gram-positive bacteria, moderately active against gram-negatives. They inactivate lipophilic viruses. But key limitations for professionals: they are not tuberculocidal and not sporicidal. They also don't inactivate hydrophilic viruses, so not high-level disinfectants or sterilants.
What things can reduce their effectiveness? And where are they best used? Plus, any crucial warnings about using them as antiseptics?
Unfortunately, quats are easily inactivated. They bind readily to proteins in blood, serum, milk. Also to fibers in cotton, mops, cloths, physically removing the active agent. They're also inactivated by anionic detergents, soaps, many non-ionic detergents, and ions like calcium, magnesium, iron. Given these issues, quats are mainly used for sanitizing non-critical surfaces like floors, bench tops. Their low toxicity, when diluted, led to use in food production. But here's a crucial and often overlooked warning. Quats like benzalkonium chloride are not recommended as antiseptics for general skin use. Why? Because there have been documented outbreaks where Pseudomonas and other gram-negative bacteria actually grew in contaminated quat antiseptic solutions, actively transmitting infection to patients. A huge danger.
That's critical about contamination risk. Moving on to aldehydes. These sound like they're for the really serious sterilization jobs, especially for delicate instruments.
They are indeed. Aldehydes, specifically formaldehyde and glutaraldehyde, are invaluable for high-level disinfection or sterilization of instruments that can't handle high-temperature steam. Think delicate endoscopes, respiratory therapy gear, hemodialyzers, dental tools. A big plus is their non-corrosive to metal, plastic, rubber. They have a broad spectrum of activity, working by alkylation, chemically modifying and inactivating key groups in proteins and nucleic acids, crippling the microbe.
What are the common reasons aldehydes might fail in practice?
Failures usually stem from a few things: diluting the solution below its effective concentration, the presence of organic material like blood or tissue shielding the microbes or inactivating the aldehyde, or failure of the liquid to penetrate into tiny channels or crevices in complex instruments. To help with this, automatic circulating baths are often used. They increase penetration and also reduce operator exposure to irritating fumes.
Let's look at formaldehyde first. How is it typically formulated? What are its main uses? And what are the big safety concerns?
Formaldehyde is commonly available as a 40% weight volume solution in water that's 100% formalin. An 8% formaldehyde solution has broad spectrum activity. Its sporicidal action can be slow, though maybe 18 hours. Adding 70% isopropanol speeds it up significantly. Applications include high-level disinfection of hemodialyzers, vaccine preparation, tissue preservation, and embalming. Important note, the 4% formaldehyde, 10% formalin, used for fixing tissues might not be mycobactericidal, a common misconception. Safety-wise, pungent odor, highly irritating to respiratory membranes and eyes even at 25 ppm. OSHA classifies it as a potential carcinogen and has strict exposure limits for workers.
Sounds like serious precautions needed. What about glutaraldehyde? Safer alternative or its own challenges?
Glutaraldehyde, a dialdehyde, is highly effective. Most common is a 2% weight volume solution. Crucial detail, it must be chemically activated, usually by alkalinizing it to pH 7.4-8.5 to work optimally. Activated solutions are potent, bactericidal, sporicidal, fungicidal, virucidal, both lipophilic and hydrophilic viruses. Generally has greater sporicidal activity than formaldehyde, maybe slightly less tuberculocidal. Killing mycobacteria and spores might still need prolonged exposure.
How stable are activated glutaraldehyde solutions? How do you monitor them and keep workers safe?
Key operational point. Activated solutions often have limited shelf life, maybe 14 days, due to polymerization-reducing activity. Newer formulations last longer. Since they're reused, the main reasons for losing activity are dilution from wet instruments and organic material buildup. To ensure effectiveness, test strips are widely recommended to check the concentration before each use. For worker safety, exposure above 0.2 ppm is a concern. Measures include good ventilation, exhaust hoods, tight lids, and personal protective equipment goggles, respirators, gloves.
Sounds powerful but demanding. Is there anything newer and maybe safer in this category?
Yes, a significant advance. Orthoethylaldehyde, or OPA, another phenolic dialdehyde sterilant. Its spectrum is comparable to glutaraldehyde, but here's the big plus. It's several times more rapidly bactericidal, faster reprocessing, usually a 0.55% solution.
What are OPA's specific advantages over glutaraldehyde?
Several key benefits. Faster high-level disinfection, no activation needed, simplifying use, notably less irritating to mucous membranes, often no routine exposure monitoring needed for workers, though good ventilation still advised, excellent materials compatibility, better environmental profile. OPA is highly valued for rapid disinfection or sterilization of heat-sensitive things like endoscopes, surgical instruments.
That's a significant improvement. What about superoxidized water? Sounds like advanced science, but it's practical.
It does sound futuristic, but it's practical electrochemistry. Produced by electrolyzing simple saline solution. This creates potent oxidants, mainly hypochlorous acid and chlorine. It has powerful disinfectant and sterilant properties. Commercialized as Sterilox for endoscopes, dental materials, it's rapidly bactericidal, fungicidal, tuberculocidal, and sporicidal. High-level disinfection in just 10 minutes.
And its safety profile? Environmental impact.
That's another major plus. Generally considered non-toxic, non-irritating at effective concentrations. Its breakdown products are environmentally benign, no special disposal needed. Very appealing compared to many chemical sterilants requiring complex waste handling.
Let's move to peroxygen compounds. Hydrogen peroxide and peracetic acid.
Environmentally friendly oxidizers.
They are indeed. Peroxygens have high killing activity, broad-spectrum bacteria, spores, viruses, fungi at the right concentrations. Key advantage, their decomposition products are typically non-toxic, don't harm the environment, usually water, oxygen, acetic acid. Powerful oxidizers, primarily used as high-level disinfectants and sterilants. Let's break down hydrogen peroxide first. How effective is it? How is it used beyond just surface cleaning?
Hydrogen peroxide is very effective, especially for inanimate objects with low organic content. In modern healthcare, cutting-edge systems now produce hydrogen peroxide vapor or dry mist for comprehensive room decontamination, hands-free disinfection of entire rooms, high level of environmental control. Worth noting, bugs producing catalase and peroxidase can rapidly degrade H2O2 into oxygen and water, a resistance mechanism. Concentrated solutions, 90% H2O2, are made electrochemically. Diluted to 6% and 3% in pure water, they're quite stable. Key point, concentrations of 10-25% hydrogen peroxide are sporicidal.
What about vapor phase hydrogen peroxide, VPHP? How does that work as a sterile? Advantages over older methods like ethylene oxide?
VPHP is a significant advance, a cold gaseous sterilant. Big advantages over toxic carcinogenic gases like ethylene oxide or formaldehyde. Doesn't need a pressurized chamber. Active at low temps, even 4 degrees C, and low concentrations, around 4 mg. Ideal for heat-sensitive items. Incompatible with liquids and cellulose. Penetrates some plastics, though complex lumens can be a challenge. Automated equipment using VPHP or H2O2 with formic acid is now routine for sterilizing things like endoscopes, faster and safer than chemical liquid immersion.
And peracetic acid. How does it compare to hydrogen peroxide? Broader applications, maybe in industry.
Peracetic acid is another powerful oxidizer, made commercially from H2O2 acetic acid catalyst. Explosive pure, so used dilute, transport in emptied caps, releases oxygen. Professional insight. Peracetic acid is actually more active than hydrogen peroxide as both bactericide and sporicide. 250-500 ppm, effective against many bacteria in 5 minutes, pH 720 degrees C. Spores inactivated by 530,000 ppm. Robust even with some organic matter. Bactericidal activity varies beyond healthcare. Automated machines use 0.1–0.5% buffered liquid for medical, surgical, dental, instruments, hemodialyzers, extensively used in food processing and beverage industries. Why? Breakdown products dilute, don't cause odor, taste toxicity. Rinsing often unnecessary, very efficient. Toxicity profile, potent tumor promoter, weak carcinogen, not mutagenic in Ames tests.
From chemicals to light, ultraviolet irradiation. How is this used for decontamination?
UV irradiation, specifically UVC light, is a physical disinfection method gaining traction in healthcare, used as an alternative for disinfecting patient care areas, often via automated systems, mobile robots, minimizing staff exposure. Direct UV is harmful. UDC damages microbial DNA, stops replication. Rapid cytal activity against many pathogens, effective for most vegetative bacteria in 25 minutes. Significantly shown effective against C. difficile spores in 1 hour. Valuable for terminal cleaning of isolation rooms.
Finally, heavy metals, mercury, silver. Sound historical. What's their current status?
You're mostly right. Rarely used as primary disinfectants now due to drawbacks, though niche uses remain. Mercury, environmental hazard, toxic, persistent. Some bacteria even develop plasmid-mediated resistance. Hypersensitivity to thimerosal, mercury compound, is common, up to 40%, absorbed by rubber plastic closures. However, thimerosal, very low concentrations, 0.001–0.004%, is still safely used as a preservative in some multi-dose vaccines, antitoxins, immune sylvia. Benefits outweigh risks in these specific uses.
And silver. I know it's still used sometimes.
Inorganic silver salts are strongly bactericidal. Silver nitrate, 1.100, was historically used in newborns' eyes to prevent gonococcal infection, now replaced by antibiotic ointments. But silver still has a place. Silver sulfadiazine slowly releases silver, used to suppress bacterial growth in burn wounds, provides sustained antimicrobial activity there, so targeted utility remains.
Sterilants and preservatives, broader applications.
We've thoroughly examined disinfectants and antiseptics. Now let's hone in on sterilants agents achieving absolute cleanliness, killing even spores. What's the traditional gold standard for this?
The foundational method for heat-resistant items is pressurized steam autoclaving, exposing materials to superheated steam, typically 120 degrees for 30 minutes at pressure. Incredibly effective. Moist heat rapidly denatures proteins, destroys nucleic acids, kills everything, including spores. Gold standard for heat-stable stuff.
But not everything can take that heat. For delicate things, what were the traditional alternatives?
Exactly. For heat-sensitive items, delicate scopes, plastics, rubber ethylene oxide, or EO, has been a traditional alternative. Gas, usually diluted with fluorocarbon or CO2 to reduce explosion risk, used at 440–1200 milligl, 45–60 degrees C, 30–60% humidity. Higher concentrations help penetration.
Ethylene oxide sounds potent, but I've heard serious safety and environmental concerns. Is it still widely accepted?
You've identified a critical challenge. EO is effective, but unequivocally classified as a mutagen and known human carcinogen.
Yeah.
OSHA has a strict exposure limit, 1 ppm TWA. Needs sophisticated controls, exhaust systems, strict protocols to protect workers. Because of these risks, plus long aeration times needed to remove residual EO, there's been a significant push towards alternatives offering similar efficacy with better safety and environmental profiles.
What are those alternatives replacing or reducing reliance on EO?
The field has inundated. Alternatives now common include vapor phase, hydrogen peroxide, VPHP, peracetic acid, ozone, gas plasma, like H2O2 plasma, chlorine dioxide, formaldehyde, still with concerns, propylene oxide. Each has pros and cons, effectiveness, material compatibility, safety. Among these, automated peracetic acid systems are widely adopted for high-level decontamination sterilization of sensitive things like endoscopes, hemodialyzers. Why? Proven effectiveness, automation, less operator exposure, low toxicity of residual products, water, acetic acid.
Finally, let's discuss preservatives. How do they fit in? Where are they essential?
Preservatives are a specific vital application of antimicrobials. Purpose: prevent microbial growth in products over time, maintaining integrity, safety, efficacy. Crucial in several areas: pharmaceuticals, especially multi-dose vials, lab seri agents, Cosmetics, contact lens solutions. Think multi-use medication vials accessed repeatedly, or multi-dose inostrops. They need preservatives to stay sterile after opening, prevent contamination.
What makes a good preservative? Can you give common examples?
Must meet stringent criteria. Non-irritating, non-toxic to tissues. Effective against likely contaminants for that product. Sufficient solubility and stability in the formulation over its shelf life. Common agents include organic acids, benzoic acid salts, parabens, esters of p-hydroxybenzoic acid, sorbic acid salts, certain phenolics, quaternary ammonium compounds, specific alcohols, even mercurials like thimerosal, very low safe concentrations, 0.0001, 0.0004% in specialized products. It's complex formulation science.
Case study, revisit putting knowledge into practice.
All right, immense amount of ground covered. From intricate internal antimicrobials to powerful environmental guardians. Let's bring it all together, solidify your mastery by revisiting that clinical case study. Remember our 56-year-old man admitted for pneumonia, then developed C. diff on day 7, confirmed by stool test.
This is exactly where all this specific knowledge becomes practical. Shows how professionals apply these insights. For his C. diff infection, we discussed options. Based on our deep dive, the clear choice now is oral Fidaxomicin as the preferred first-line drug. Why? Evidence shows it leads to significantly lower rates of relapse compared to oral vancomycin, a huge issue with C. diff. Plus, its negligible systemic absorption means it concentrates right in the gut lumen, minimizing systemic side effects.
So if Fidaxomicin's a preferred first line, where does oral vancomycin fit? And what about metronidazole, our very first drug?
Oral vancomycin remains incredibly important, an effective alternate first-line agent. Clinically, it's very often used preferentially over Fidaxomicin, primarily due to its significantly lower cost. That's a real factor. As for metronidazole, our discussion highlighted its clinical inferiority to oral vancomycin for C. diff. So metronidazole alone should generally be reserved only for mild C. diff cases if patients can't tolerate preferred options. Critically, in severe fulminant C. diff, metronidazole still plays a vital role, but as an additional agent, usually IV combined with oral vancomycin for a multi-pronged attack. Understanding these nuances is crucial.
Makes perfect sense. Mapping drug features to clinical scenarios. Now, the second part, cleaning the patient's old room. What product should housekeeping use? And critically, why that specific agent for C. diff?
This directly tests understanding of disinfectants, especially the spore challenge. For a room after a C. diff patient, it's paramount to use a sporicidal agent. Based on our chlorine discussion, a bleach solution, specifically 1.10 household bleach, giving 5,000 ppm available chlorine is the widely recommended standard. The why is the professional insight. We learned concentrations up to 5,000 ppm are needed to reliably kill bacterial spores. C. diff forms highly resistant spores that persist, causing reinfection. Simple, non-sporicidal disinfectants would fail.
So it's not just general cleaning, but specifically tackling those tough spores.
Precisely. While bleach is primary, effective, cheap, professionals should recall other sporicidal disinfectants we discussed could work too. Certain aldehydes, glutaraldehyde, OPA, peroxygen compounds, concentrated H2O2, peracetic acid. The key is selecting an agent-proven sporicidal, using it at the right concentration and contact time to neutralize the C. diff spore threat. It all comes back to understanding the agent versus the specific microbial challenge.
And just like that, you've traversed the complex, fascinating world of antimicrobials. We've journeyed from precise internal warfare, like metronidazole activating inside the enemy, to robust environmental guardians like bleach, needing specific concentrations for spores. We've uncovered remarkable mechanisms scrambling DNA, inhibiting proteins, tearing apart membranes, and learned how absolutely critical precision is pH for urinary antiseptics, safety for potent sterilants.
And through this deep dive, our aim was for you to achieve that profound understanding, those aha moments, the subtle but profound differences between disinfectant and antiseptic, why concentration and conditions are paramount, the constant battle against resistance. These agents, often unseen, are truly foundational to modern medicine and public health, working behind the scenes. You now possess insight reflecting real mastery.
This raises an important question for you, our discerning listener. As we gain deeper insights into the microbial world and these tools, how might future innovations reshape healthcare and daily hygiene? What surprising new strategies might emerge? Maybe harnessing biology differently, or rediscovering ancient wisdom.
What aspects stood out most to you? We hope this deep dive encourages you to consider the implications of this mastery in your own life, understanding a prescription, evaluating a cleaner, or simply appreciating the unseen efforts keeping us safe.